begin with a historical review of internal fixation and compound injuries, talk a little bit about what we know about the basic science of fixation and compound or infected fractures, move on to review a little bit regarding the timing of fixation and compound fractures, and then finish up with some future strategies that we may be able to employ that will allow us to decrease the infection risk following open reduction and internal fixation. Historically, internal fixation was avoided in compound injuries because of the high infection risk. But in many open injuries, especially intra-articular fractures, the patient's functional recovery was sacrificed in the absence of ORIF. In 1979, Clinical Orthopaedics and Related Research published 2 reports of the outcome of open fracture treated by open reduction and internal fixation. One group was from the AO group from Switzerland, where they reported on 191 open fractures treated with early ORIF, showing a superficial infection rate of 4.5%, a deep infection rate of 3%, and 7% rate of development of osteomyelitis, with only 2 cases requiring amputation. The second report in this same journal issue was from Mike Chapman from the United States, who reported on 94 open fractures treated by early ORIF. He reported a 10.6% overall infection rate. And you see the increasing infection rate as you increase the Gestio classification, ranging from 1.9% in type 1 injuries up to 41% in type 3. And in this series of 94 cases, only 1 case developed chronic osteomyelitis. Well, since these 2 reports in 1979, internal fixation has been increasingly used successfully in a large percentage of open fractures. Of course, with an emphasis on a thorough debridement prior to internal fixation, as has already been discussed. Well, we know that bacteria can rapidly adhere to any implant surface. Biofilms, which form on the implant surface, shelters the bacteria and encourages the persistence of infection. Furthermore, implant infecting bacteria can elude innate and adaptive host defenses, as well as standard antiseptics and antibiotics. In 1987, Christina popularized the concept of the race for the surface following introduction of an implant. In this race for the surface, either there's tissue integration or there's bacterial adhesion and colonization. If the host cells integrate onto the surface first, then bacterial colonization will be actively inhibited, and the implant or biomaterial becomes tissue integrated. However, in the more common scenario, bacteria colonize the surface first, and a mucopolysaccharide biofilm forms, which is conducive to further bacterial growth. It enhances bacterial nutrition, promotes further bacterial aggregation, and inhibits the immune response and interferes with phagocytosis. Well, what do we know about the role of stability in open fractures? We know from basic science studies that stabilized open fractures are less susceptible to infection. Stabilization may reduce the amount of continued soft tissue damage, making the wound less hospitable for bacterial growth. In this study of a femoral osteotomy model infected with Staph aureus, the infection rate without stabilization was 71%, but when this femoral osteotomy was stabilized with a K-wire, the infection rate dropped to 38%. However, in the same model, when a gram-negative organism was used, the stabilization actually resulted in a higher infection rate. So there may be some issues regarding the type of bacteria involved. In this rabbit tibial fracture model, all infected with Staph aureus, investigators compared a stable fixation with a dynamic compression plate with a loose intramedullary nail and showed a much lower infection rate with more rigid fixation using a dynamic compression plate compared to a loose intramedullary nail, almost half the rate lower with stable fixation. Well, what do we know about the timing of internal fixation? Unfortunately, there is no solid clinical data to guide the timing of definitive fixation. Immediate open reduction and internal fixation is usually following a thorough debridement, except when there's gross contamination, such as manure, embedded dirt, or pond or river injuries. It's important to realize that definitive fixation may preclude future debridement, especially of the intramedullary canal. In contrast, external fixation, which we'll hear about next, can be easily loosened to re-expose the intramedullary canal for serial debridements. Well, what about the timing of internal fixation? Typically should be performed at the time of the final debridement, and that may be the initial debridement if there's only going to be a single debridement, and it should be as close to the timing of wound closure or coverage as possible so that the wound is covered quickly following internal fixation. Well, what are some strategies we can use to decrease the infection risk, both present and future? Well, one of the simplest strategies, perhaps, is after debridement to re-prep and drape, use new gloves, new gowns, new instruments. Antibiotic bead pouch, which has already been mentioned, is useful for open wounds prior to soft tissue coverage, provides a high local antibiotic concentration, and avoids desiccation of the bone and soft tissues. Another possible method that can be used to decrease the infection risk is injection of antibiotics in the open fracture site. Lawrence Danners reported on 351 open fractures, a control group of 183 who received systematic antibiotics alone, and an intervention group in which they locally administered aminoglycoside at the time of the index surgical procedure. In addition, these patients received systemic antibiotics. So following wound closure, they injected 80 milligrams of an aminoglycoside that was diluted in 40 mLs of normal saline. And they injected it down to the bone at the open fracture site and around the implant, such that this aqueous solution filled the wound cavity. They found the total infection rate, both deep and superficial, significantly lower in the intervention group, decreasing almost a half from 19.7% in the control group to 9.5% in the group in which the aminoglycoside injection had occurred. The deep infection rate was also significantly lower in the intervention group. It was 14.2% in the control group and 6% in the intervention group. Multivariate analysis was performed to adjust for possible confounding factors. The administration of local antibiotics was found to be an independent predictor for lower infection rates, with an odds ratio of 2.6 for all infections and an odds ratio of 3.0 for deep infections. Well, multiple studies have explored the use of topical antibiotic powder application, especially in prolonged spine procedures. And I know there is at least one ongoing clinical trial in open fractures. Coating of implants has also been another method that has been studied. Synthes has commercialized in certain European countries this gentamicin-coated tibial nail, which consists of a fully resorbable polylactic matrix that has a burst release of about 80% of the gentamicin antibiotics within the first 48 hours after nail implantation. In 2 case series, there were no infections after a 1-year follow-up. A multi-center prospective study of almost 100 patients found that there are 35 patients undergoing surgery for open fractures, while the others were either closed or revision surgeries. There were 3 patients with type 3 A or B open tibial fractures that developed surgical site infections of those 35 open fractures, despite the use of the antibiotic-coated tibial nail. This same antibiotic coating concept has also been applied to the use of plates, using, rather than an actual coating on the plate itself, an antibiotic plate sleeve. So a thin film polyester sleeve, which the plate can be slipped into, that can then be combined with various different antibiotics or antiseptics. In this case, these sleeves were combined or impregnated with either gentamicin, triclosan, or both. And this study reported in Veterinary Surgery in 2012 was just a feasibility study showing that the sleeves did elute the antibiotics, but they really did not compare it to an infected animal model. This same sleeve antibiotic concept has been commercialized regarding cardiac devices, implanted pacemakers, and implantable defibrillators. This is a product that has both minocycline and rifampin, and the use of this antibiotic impregnated sleeve around the cardiac implant has shown a 40% reduction in major infections. More recently, the use of antibiotic-loaded hydrogels has been investigated. Hydrogels are a 3D network of cross-linked polymer chains of hyaluronic acid. They are injectable, and they can be combined with various antibiotics. And unlike antibiotic beads made of polymethyl methacrylate, are easily resorbable. And this outweighs some of the limitations of antibiotic beads in that they have a better antibiotic release profile and are biodegradable. In this study, looking at a single-stage revision for an MRSA-infected tibial intramedullary nail, the investigators looked at local gentamicin and vancomycin therapy delivered either via hydrogel or a polymethyl methacrylate carrier. And the antibiotic delivery via the hydrogel resulted in a 10 to 100 times greater local concentration of antibiotics within the first 2 to 3 days. So in summary, as we've learned and as the prior speakers have shared, internal fixation is safe in selected compound fractures following a thorough debridement. The debridement is an essential step in terms of the safety of internal fixation in compound injuries. And we should always be mindful of using any steps we can to minimize implant colonization risks to avoid the problems associated with the race for the surface, to avoid bacterial colonization and the biofilm formation. Thank you. And